Welcome to Health Management Academy. In part 2 of the Resource Management Operations video, we'll be talking about preventable hospital readmissions.
Preventing unnecessary hospital readmissions is a complex, system-wide goal that involves hospitals, physicians, and other providers who manage patients' care, as well as patients and their families. Preventing avoidable hospital readmissions protects patients from the risks associated with hospital stays, such as infection, falls, or medication errors. For the healthcare industry, readmitted patients, especially those on Medicare, are a source of high cost. Because of this, Medicare and other payers are implementing programs that reduce payments to specified hospitals for certain readmissions. The basic components of a hospital readmission prevention program include the implementation of the risk stratification assessment tool, an initial discharge screening assessment during the first resource management review, a health literacy assessment. We should determine if gaps exist in the patient's understanding of their disease process. Consults are sent to the resource management for all patients at moderate to high risk for readmission. Proactive discharge planning, collaborative care rounds, early identification of actual or potential problems and interdisciplinary input regarding the patient's discharge needs. A readmission questionnaire is conducted on all patients readmitted to the hospital within 30 days. Focus on improved education of patients with core measure diagnosis. The development of community support groups for patients with a diagnosis of CHF, COPD, and pneumonia. A structured discharge checklist. Teach back. The patient or patient's educational partner should be able to teach back to the nurse the red flags or symptoms that signify their condition is getting worse. A discharge plan finalization and clear documentation of the discharge plan by the resource management. Standardize a checklist for critical items a patient must know prior to discharge. Follow-up appointment with PCP should be scheduled prior to the patient's discharge. An automatic trigger to the resource management for all patients representing for a readmission within 30 days. Review of the discharge plan by the Director of Resource Management for all patients readmitted within 30 days. The development of a readmission prevention panel.
I noticed Mrs. Davis came in last night. She was just discharged a couple of days ago. Do you know what happened?
Yes, she did come in with a CHF exacerbation. She said when she went home that the home health agency never came out to see her. Her old chart did say that she was set up with quality home care.
Well, I noticed that we did a follow-up call on her, but she said everything was going okay. She didn't mention to me that the home health agency had not been there. When I do her assessment, I'll make some calls, see what happened. Would you please put in a consult so that we can follow up with her and make sure she doesn't drop off the charts?
Yes, I will.
Okay. Thank you, Kim.
Coordination of post-acute services, in addition to appropriate discharge planning assessments, is crucial to helping prevent a possible readmission. Concurrent analysis with the patient will bring to light any real or potential root cause for the readmission and will provide insight prior to contacting the post-acute provider. Communication with the post-acute provider is essential to promote continuity and positive outcomes.
Hey, Dawn.
Hey, Jackie, what's going on?
Hey, listen, I just finished my rounds on 6 West, and I was a little concerned because I had another patient that wasn't seen by Quality Home Health the day of discharge.
That makes 5 this month. I think I'm going to give Jan, Quality Home Health Care, a call. We've already got our community meeting scheduled, but they're new to the area, so I'm going to go ahead and bring them in. Did you find anything else out on your worksheet?
I was a little concerned because her appointment was 2 weeks out, and I need to call Dr. Jones and see if I can reschedule that for within 7 days of discharge. And here are the rest of my readmit sheets. And I'll turn those over to you, and I'll see you later for lunch, okay?
All right, I'll get them in.
All right.
See you then.
See you later. Bye.
Bye.
The concurrent readmission analysis worksheet will help assist you in identifying your individual hospital readmission trends. In addition, the relationships built with your post-acute provider community will increase transparency and prove beneficial in identifying those processes that externally contribute to your readmissions.
Hi Jan, this is Dawn calling from Sparks Hospital. I'd like to follow up on a few referrals we'd sent your way, and I'd also like to invite you to our community readmission work group. Do you got a minute to talk?
Hey Dawn, I've got a minute. What can I help you with?
Well, I thought since your company is new to the community, I'm not sure if you're aware of our community readmission work group. On a monthly basis, on the hospital side, we look at all patients that are readmitted to our facility, and we evaluate to see if there are any trends. We review the trends, and as a group, we decide how to address them. And then it's up to each provider to come before our group and share what services they provide. After that initial presentation, no more marketing activities are allowed unless additional services are added.
Are each agency's data presented at that forum?
In the group setting, we do present aggregate data because we want the meeting to focus on the resolution of the issues and not an individual provider. We will, however, share an individual's provider's data if asked or if a significant trend is identified.
Wow, that sounds great. When's the next meeting?
It's going to be at the end of the month, so I'll send you a postcard and email you once we finalize our date.
Very good. Now, did you need to talk to me about referrals too?
Yeah, during this last month, we've had 5 readmissions specifically referred to your agency that have reported they didn't get a visit from your staff. We didn't have this issue prior to the purchase, and I was wondering if you were aware of this.
No, Dawn, I wasn't aware of that, but if you'll give me the patient-specific information, I'll be glad to research them and get back to you.
As you can see, communication across the continuum is essential. Each post-acute provider's perspective adds value to the process. At the inception of a community readmission work group, it is very important that the groundwork be laid so all members of the team understand the anticipated outcome. Make sure all of the key stakeholders understand the structure, which includes meeting locations and frequency, minimum attendance requirements, purpose and goal of the meeting, no individual marketing activities, and high-level review of hospital-identified trends. These 5 items are essential to creating an environment in which the patients are the focus and not the individual provider groups.
So if you all open your folders, you'll find our readmission numbers for the month of September. I've got them up here. Also, we had 24 readmissions for September. 4 of those were scheduled readmissions with 70%. 5 were no home health follow-up at 21%. 8 were from a skilled nursing facility at 33%. And of the 8, 4 of those came from a single facility. 5 we found out didn't have services post-discharge. This total 21%. 2 did not get their prescriptions filled for 8%. And then 6 returned to the hospital prior to their PCP follow-up appointment.
So of the ones that were admitted from home health, was there any particular reason for the majority of them?
What we found is most of them were readmitted with UTI and dehydration. And so we've noticed this trend over the last 2 or 3 meetings. What we've done is we've met with our CNO, we've met with the nursing education department. We're pulling that information together to roll out education for UTIs, intake, output, dehydration, and we hope to be able to push that out to the home health agencies.
My staff would certainly benefit from a refresher education. Would you be willing to offer it for like after-hours nurses?
Yes, we'll work with anybody on a schedule. The best option maybe is once we get that education together is to video that. That way we can give it to you. You can offer it to your staff that are on vacation or not available to see that. And after talking with our ER physicians and the attending physicians, we noticed that we weren't really doing a good job of communicating an entire clinical picture before the patient returns to the hospital.
Well, I think communication needs to be more consistent from a patient that's going to home health or vice versa to the hospital. Our medical director, who's also an admitter to the hospital, we could work with him to develop a tool for all home health agencies to use if the group's willing to accept that.
I think that'd be great. Can I have any volunteers for this project? Sure. Everybody say aye, raise your hand. Okay, good job. One of the things we did find out with this particular agency, I did visit with them, and what we found out with those 4 that trended out were there were some transmission problems. Once we got all of the referral, it was hard to get that transmitted, so that agency has already put a process in place to prevent that from happening again.
So do we actually know how many patients went home with no services when they could have qualified for alternate services?
That's a good question, and we've recently started a program in our emergency department. And what we found out since we've had that program is 3 of the 5 admissions so far that have been readmitted through the ER were patients that didn't have any services and probably could have been sent from the ER with those services.
Transitions between alternate care settings are some of the most vulnerable times for patients. In order for the Community Readmission Work Group to identify root causes, you must stratify the data by post-acute provider group, diagnosis and specific comorbid conditions, by clinician, time frame for readmission, same day, 7, 14, 30, education provided, and timing of follow-up appointment. While there are many other factors to consider, such as medication reconciliation and health literacy, the entire healthcare community must work together to promote continuity during transitions of care and decrease readmissions across care settings.